Recording.
It is recording.
Perfect.
Oh,
Thank
okay.
you. Thank you.
Perfect. Okay. All right. So good afternoon, everyone, and good morning to some, good evening to some. Happy tea time every time. So welcome to Innovations in Aging Research webinar series. I am your host for this afternoon, Milan Sang. And just a little bit of plugging about myself. My research interests are in complementary rehabilitation, focusing on martial arts and dance. And yeah, welcome to our channel and welcome to a webinar in AJ Research. Okay, so we are inviting you here today to listen to a few um, thoughts and of course to listen to our guest speaker. But before that, let me just have a few advertisements. This webinar is brought to you by ACRM's Aging Research and Geriatric Rehabilitation Networking Group. We are welcoming new members, so if you are interested to build up your research on aging and geriatrics, check out our webpage. It's flashed on your screen. And please join our monthly meetings and see what we are up to. You can drop us a line. You can also email our chairperson, Dr. Saurabh Mehta, through the email flashed on your screen. We will be having our annual conference this fall in Chicago, October 27 to 30. So please check out the rates and the schedule. It's an acrm.org/2025. Okay, so these are a few of our advertisements. We are still, I think we are in our last wave for our proposals. So check out our website. And if you're still on go, you can still submit for your proposals. Okay, so here we go. We also have our journal, Archives of Physical Medicine and Rehabilitation. So if you submit your proposal and it got accepted in our annual conference, it will also reflect here your conference abstract. So feel free to search up our conference this October. All right, so I guess that's it for our advertisements. All right, so let's get to our speakers. So to this afternoon, we are welcoming Dr. Hiral Master as our speaker this afternoon. She will be speaking about leveraging large data and wearables in clinical research and rehabilitation. So let me just introduce our speaker today. So Dr. Hiral is a licensed physical therapist and a certified public health professional. She has a PhD in clinical and translational research. She currently works for the All of Us Data and Research Center, DRC, and she serves as Research Data Innovation Lead, where she focuses on scientific initiatives related to phenotyping and digital health data and outreach activities within educational and research settings. So just a few reminders to everyone. Please keep your mic on mute during the entire presentation. Have your headphones ready. Use the chat for our question and answer. We will be reading it at the last 20 minutes of our meeting. So be ready, be on time, be courteous, and be flexible. So without further ado, thank you so much. Here's Dr. Hira. I'll be closing my screen now.
Thank you so much for that introduction, Naomi. Can I share my screen?
Yes, yes. Wait, is my screen still sharing?
Mm-hmm. Yep.
Mm, share. Hmm. Lori, there's
Uh,
no stop share.
Hiral, if you actually just hit the screen share, I don't know if it will just boot Mel. There you go. Good.
Okay.
Okay, there.
Can you guys? Okay.
Yep.
Can you guys? Great. Perfect. Okay. Uh, Great. I want to make sure you guys can see my screen properly. Cool. So thank you so much, Naomi, for the introduction. I'll get started with my presentation. And yeah, please ask me questions. If there's anything that I don't make sense, let me know. And think of this presentation as more like, you know, not as a presentation, but more like as a discussion or like as a research conversation that we are having. So my goal of presentation is to understand how to use wearables and big data to better understand and explore the health outcomes after spine surgery, how we can leverage wearables to design interventions to promote physical activity, and also how we can leverage longitudinal data from wearables to answer different clinical research questions. So hopefully my presentation is going to highlight each of these sections and will kickstart some of the conversations. So overall, what I am really interested is as a physical therapist, I see a lot of patients with musculoskeletal pain disorders, and definitely I'm really interested in better understanding their short and long term outcomes. And with the advance of technology that has happened, healthcare is no exception, and it has entered the healthcare field as well, especially rehabilitation. And I was really interested in how wearables can provide that digital biomarker insights into better understanding this disease trajectory in form of first physical activity. Because as a physical therapist, we understand movement and activity, and getting patients back to being active is one of our main primary uh, uh, treatment agenda that we work with our patients. So that's what inspired my research line of questions. First is like spine surgery. So a lot of like spine surgery is highly prevalent in the United States of America, and it has like healthcare costs associated with it. So one thing after spine surgery is the patients undergo rehabilitation, and I was really interested in understanding, what are the markers that will help understand better outcomes at 6 months follow-up. And based on prior literature, especially the study done by Gilmore et al., they found that engaging in physical activity, especially early post-operative walking, during early post-operative period, is related to better outcomes in spine surgery. Now, this paper really provided like, yes, like this does make sense. But my next line of questioning was when I want to consult with my patients, they'll ask me how much, like, hey Hero, how much do I need to be active? Like 5,000, 6,000, 10,000? Tell me how much steps per day is enough for me to have a good outcome after my surgery? Or else, even as a healthcare provider, like what is the goal that I should be working towards to better understand? So, for instance, like how we have thresholds for physical functioning, or how we understand different values on different tests that we do on our patients. I was interested in knowing physical activity as like different markers or thresholds that will better inform not only communication with patients, but also while designing interventions, what are the values or what are the thresholds I should even be looking for, or healthcare professionals should even be looking for. So I defined my primary outcome over here as best outcome. Again, I know this terminology does definitely raise, Hiral, what do you mean by best outcome? But this is definitely a well-known terminology in spine surgery world. So basically, they define best outcome as minimal symptom stage, which is a composite measure of using disability, back pain, and leg pain score. So if you achieve lower scores on disability, back pain, and low back pain, leg pain and disability, then you have a then it's called like you have achieved a minimal symptom stage. So that was my primary outcome. And my secondary outcome that for this project was no opioid use. like how many people do not use opioids. So that was again, we defined using a self-report questionnaire, a single item questionnaire, and we recorded that responses at preoperative 6 weeks and 12 months after surgery. Again, just for awareness, this data is comparable to prescription drug monitoring program reporting or national prescription records. Because again, here we were not interested in knowing how much is the opioid use, but just like whether someone is using opioids or not using opioids at a high level. This manuscript is accepted at Archives of Physical Medicine and Rehabilitation, and we did give a podcast at Rehabcast. So if you guys are interested in knowing more study details, feel free to listen to the podcast. So just on a high level, what we did is we had 248 patients who underwent laminectomy procedure. They were recruited from two sites. One is Vanderbilt University Medical Center, and second is Johns Hopkins uh, uh, Johns Hopkins Medical Center. And then this study was funded by PCORI. And our primary analysis showed that there was no significant outcome differences between two groups. So basically, this is a secondary data analysis of a randomized clinical trial that was looking into investigating the effectiveness of cognitive behavior, physical therapy, and education. So therefore, for my this study, what I did is I grouped people from both the interventions, both the groups into one, and I analyzed them for answering this research question. My exposure was steps per day, which was quantified using Actigraph GD3X, which is like a research grade wearables. What happens is we tell patients to wear this monitor over their waist, where the monitor lies over the right hip. And patients are instructed to wear, during the waking hours. So we only included data if they wore the monitor for at least 10 hours and for at least 3 days for 1 week. Now, this steps per day was assessed at 6 weeks after spine surgery. And then we ran our models, like regression models. And what we found is steps per day was associated, like if you take higher steps per day, like 1,000 steps per day more, then it was resulted into 41% higher odds of achieving best outcome, that is minimal symptom stage, and 38% of no opioid use. So these models were definitely adjusted for all the potential covariates as listed. I'm not going to go in detail. So the key take-home message from this study, what I want to reinforce is we use wearables and secondary data analysis from a randomized clinical trial to gain insights into and to further a research question line of like how much activity is in fact meaningful during the early post-operative period after spine surgery. And what we found is, yes, taking more steps per day is uh, is associated with higher odds of achieving best outcome and no opioid use. We also found like a minimal, like an initial recommendation. So we did like sensitivity and specificity analysis, computed the AUC, and what we found that 3,500 steps per day MESA was an initial recommendation for these patients after spine surgery. So we did found those two as a message. And this study, this secondary data analysis really reinforced that yes, interventions are needed to increase steps per day after lumbar spine surgery. So what happens is so based on secondary data analysis, literature review, like systematic reviews, prior studies, or looking at the studies in other patient population like knee osteoarthritis, total knee replacements, other musculoskeletal disorders, like doing like a composite study of what's all available out there was led to the foundation of my pilot randomized clinical trial, which I led and designed. So this study has been accepted at PTJ, and we did do again like a podcast with the PTJ author, Physical Therapy Journal. So feel free to hear our podcast if you're interested in knowing more details. But on a high level, what I want to focus in this presentation is uh, how we are using these stuff to inform and advance our research line and get insights, and how we can refine our research questions, how we can collaborate, and how we can advance our evidence-based practice. So for this, what we did is, based on the prior studies, what we did is we designed a randomized feasibility trial where my goal was we will do a preoperative screening, confirm the eligibility, consent. We will take a we'll also take our measurements preoperatively, but the true baseline would be 2 weeks after spine surgery. After getting that 2 weeks after spine surgery baseline values, we would then randomize them to either usual care or physical activity telehealth intervention. And then we will follow up this patient for 6 and 12 months after spine surgery. So what my goal of this intervention was I was really interested in showing like how can we promote physical activity. Like, it's easy to say, tell your patients to be active, or it's easy to say, okay, I need to walk more steps. But again, after undergoing major surgery, there is like having a program or having a pathway of how to become active in a guided manner is really helpful to prevent relapse of symptoms or to ensure that the patients are not overdoing or underdoing any activities. So what we did is, as a part of our intervention, we gave Fitbit device. We told our patients that please wear this monitor for at least 8 weeks, monitor your steps per day, and at least sync your steps per day with your app. And I'll tell you why. Uh, then we had this phone sessions with our licensed physical therapist who is also trained in motivational interviewing. So we ensured our physical therapist who is trained in motivational interviewing conducts this 8 brief sessions over Zoom, and we had weekly physical activity phone sessions starting 2 weeks after surgery. And the goal of that sessions was to do smart goal settings and progression and motivational interviewing. So that was our thing. And we also again, we understand these patients are a little older, or we want to make sure that technology doesn't become overwhelming aspect to it. So we did give them a manual, so like paperwork which described our interventions. Of someone who is interested in reading the papers, or someone who is interested, what, I can't take care of these things. I can't sync with my app. Okay, we also gave them like paper forms so that they can keep track of it in paper forms if that's what they are interested. We just provide them an alternative mechanism so that we are capturing, and technology doesn't become a barrier, but it actually becomes like an adjunct, and we can leverage and we can successfully conduct our intervention for these patients. So what we did after that is, this is a key thing. What happens is whenever I tell my patients like, hey, sync your device with your app and tell me how much you walk past 1 week. Sometimes patient may not sync their device, and it's often based on recall value. And again, after spine surgery, there's lots going on in patient's life, and it's people might not, it's difficult, or at the meeting or at the session, if I say, oh, how much did you walk past week? Tell me. That answer may be subjected to recall bias. So therefore, what we did is we wanted to base our goals at real-time monitoring. So what happened that at the time of an randomization, a patient was randomized to physical activity intervention group, they had to sync their Fitbit to Fitabase, which is like a third-party integrator, like a third-party platform. And our physical therapist had access to this Fitabase. So every week when, a therapist would do a Zoom session, she would pull up this Fitabase, uh, not like first just as a way of engaging the patients, like, hey, this is what I'm seeing, tell me what's going on. Or sometimes technology may not be right. Hey, it seems I bought the device but something did not capture. So it's actually kind of like a conversation starter to get patients buy-in and to basically kickstart the conversation and minimize the recall bias. So what we did is we then underwent our consort diagram. We saw that our recruitment rate was 41%. Remember, this trial was done during pandemic. So this was done between 2020 and 2021. So this was at a peak of COVID pandemic. Therefore, we went with the telehealth and the Zoom route. And our randomization rate was 62%. However, retention rate was 100% in both the groups. So like we were able to retain people at 3 and 6 months. If you see our baseline characteristics, it was we stopped at 16 because we got funding for the full trial. So this was a feasibility trial, and we stopped our recruitment at 16 because we realized that we have learned sufficient, and our trial for full trial is right now in process. We would be publishing soon. So, but what this feasibility trial gives us is like it really showed that we had randomization imbalance. So if you see, our physical activity intervention group was more like the average age was 71 versus the usual care was 61 years of age. So there was definitely a randomization imbalance. However, that it could be because of the smaller sample size. And even if you see otherwise, things were pretty comparable, but on a high level, we did see some imbalance in terms of age between our two groups. In terms of intervention acceptability, I just want to highlight some of the participants' comments because, again, all of these sessions were recorded, and we did do like a acceptability survey, like at the end, like an acceptability measure to basically see if our intervention is even helpful to these participants. And what we found is, participants' comments like, hey, this walking program was a motivator to get up and get going. We basically, they were, then, our therapist was amazing every week. She set up realistic goals, understanding the challenges and benefits of walking. Being able to track daily progress and accountability was extremely beneficial. Then the other thing is also like I liked using Fitbit more than I thought I would. So this intervention was really like, okay, there is technology out over there, how it can serve as our adjunct. It's not going to replace therapy, but how it can serve as our adjunct and how it can solve our each how it can better deliver and ensure compliances and adherence with our intervention is really what we were trying to get in this study. So a key take home message is, and again, since this is more like a feasibility study, my goal was not to compare what if there was any outcome differences and any of those things. This was basically we're simply looking at, is this physical activity intervention feasible and acceptable to our patients, which it did. And when you look at the feasibility metrics and acceptability metrics, also we did identify some challenges which we were able to we were able to identify and then correct it, not correct it, but optimize it when before launching our full trial. So this was like, making sure that we have valid pre-randomization data, making sure that the variability in physical activity uh, levels is been addressed, and like making sure that the randomization is balanced. So we did have some of these challenges, and we are hoping that we made some changes into our recruitment strategies when starting our full clinical trial, and we were able to resolve some of those things. Uh, so now, this is what so this in terms of, this is how wearables was considered in terms of like, being one of a digital biomarker to provide insights into recovery, or wearables being one of the intervention modality, like, it can be serving as one of the intervention complement that, and how it can help deliver an intervention. The other stuff that I wanted to really highlight in this presentation is how, there are other large data sets that are available which provides wearables data. How can we leverage those longitudinal data from wearables? So again, going back is like, and I want to really highlight my all of us work over here. So what we know is, we all know physical activity is really important. There is guidelines, physical activity guidelines for Americans. There's WHO guidelines. Everyone, it's a well-established fact that if you walk more, you have multiple health benefits, including lower mortality risk, lower disease risk like cardiovascular disease, hypertension, diabetes, cancer, like a lot of health benefits. However, all of the prior studies which were done, they were using like either self-reported measures, or they were doing it over a brief monitoring period of like 7 days. And again, like the outcome was like relatively narrow set of outcomes. So it's not always like mortality, disease. There are other outcomes as well. So what all of us research program gave us is like it provided us an opportunity where the walking was assessed more longitudinally. It was assessed using Fitbit. So on average, the monitoring duration of the Fitbit data available on patients was around 4 years, and the outcomes came from EHR, that is electronic healthcare records. So it gave an opportunity to assess all the things that can happen over the spectrum. So all the things which would necessitate a clinical visit. When you have an electronic healthcare records data, it will provide you an insight like, okay, what would necessitate a visit to a doctor? So it would give you a wide range of diseases that you are able to study. So what we did is, before I dive in deep, is just want to give a quick highlight of what All of Us Research Program is. So All of Us Research Program is, it basically engages people who have been left out in medical research in past. It combines biological, social determinants of like at the large, like making sure it has a lot of, it looks at people holistically. So not just survey, not just wearables, but it provides survey data, electronic healthcare record data, wearables data, genomics data. So it provides like different factors so you can look at the participant on a whole, and it follows participants as they move. So it's not just one time, but it's basically longitudinal. So as participants move, grow, age, it follows participants. And again, last but not the least, it makes the data available to researcher on a secure internet connection. So it's a cloud-based platform. So basically, the collaboration becomes really, really easy where it's on a cloud platform. So you can share with researchers who have agreed data use agreements, and you can share with the research and work collaboratively with research not only within the institution but also across the institutions. Again, like participants' data, they're from different sources, they are harmonized, they are refined, and then finally a curated data repository and data dictionary is what is provided on the platform. And again, this program is committed to protecting participant privacy and maintaining broad and open access. So they want to make the data useful, but also making sure that the data is kept safe. So privacy is always, always first, and ensuring the participants is actually a part of a system, and then to ensure that participants trust. Like it's not just participants are data contributors, but they're basically part of this program and part of this research studies. And again, the data and resources are tiered. So there are different tiers available. I won't go too much in detail, but again, there are different tiers depending on the research that you're interested. You can click on one of those tiers that is applicable for your research projects. And the participants and the data is diverse. And there's a lot of data available. So like there's survey data, physical measurements data, genomics data, electronic healthcare records data. A lot of data has been available. And on a quick high level, it's like anyone, if your institution, you can confirm if your institution has an agreement. If you don't, if your institution doesn't have an agreement, you can actually apply for an agreement and you can become a register, and then you can follow through these steps and become a registered user. So all you have to go is you have to go to researchallofus.org. There's a register icon at the red top icon, and you can basically register for and access this data if you're interested. And if you have any questions, I think they have like the help icon, so you can basically ask or report any issue that you have. So now let's come back on how did we use this longitudinal Fitbit data for our to solve the question that I was talking about. So first is like definitely defining objective hypothesis, what elements are needed, setting up a team. That was what was super important. So first we decided like, okay, our objective is to ensure that we want to investigate the association between the activity, which is measured longitudinally, with a human disease, which is derived using electronic healthcare record data. And our hypothesis was lower activity would be associated with higher incident chronic disease risk. We again, this analysis was done back in 2021, so we use like version 5 data. Now version 8 is available, so definitely this is using the older data because that's what we did when we started the analysis. And we used both the daily and intraday step counts. What I mean by daily and intraday is steps per day as well as steps per minute data was used to basically get an overview of the steps data. And for the diseases, we use electronic healthcare, that is EHR data. So we use ICD value, like ICD codes, lab values, medications, and then we use survey data such as the basic survey data to get socio-demographics like patient participants' age, uh, you know, age, sex, and everything. So, and then we set up our team. Like we had a PI, programmer, co-I, statistician. So like we were all working together as a team. So definitely it was not a one person. I didn't do everything. It was like a team science. Definitely. So want to give a big shout out to all the co-authors on this paper. It was basically a team science where each one of us, we leverage our expertise and then answered this question. So what we did is we first created a workspace because again, like cloud platform was basically new for me as well. That's something was not, I was trained doing my PhD. So definitely getting exposure to cloud platform was something, a novel aspect to this kind of work at this scale. So we first created a workspace on Researcher Workbench, which is a cloud platform. And we then explored, they had some point and click tools on the Researcher Workbench, which is a cloud platform, which is cohort and dataset builder tools. So we use those point and click tools to basically had our set line of inclusion and exclusion criterias to basically identify like, what is our participants, like what is our analytical sample size? Is it something the study is even feasible? Can I even do it in all of us Researcher Workbench platform? Is it even feasible? Once we did that, then once we realized, yes, we have everything in place, that's when we started with the analysis, where we created the analytical data sets and we use embedded workbench tools to basically streamline the workflows. I highly recommend if you are not an expert in the cloud analysis to to collaborate, because again, the analysis on cloud definitely takes money. It's not like because you're using cloud resources. So definitely making sure that you do like definitely leverage all the pre-built tools like point and click tools, all the publicly available information, refining the research question as much as possible. And again, it's okay if you cannot refine it completely, you can obviously iterate over and over again. But having a streamlined workflow was really, really uh, what we say important for us because it helped us leverage and perform all the analysis in one environment where we were able to pull, transform, and conduct the analysis on the actual row level de-identified data on the platform. Once we did that, we our approach for handling such kind of data was crucial because again, the exposure and the outcome both were longitudinal with millions of billions of data. So think of it, my exposure was like after cleaning up the data, setting up all the inclusion criteria from around like 300,000, we just came to 6,000 participants because those were the participants who had valid Fitbit data and they contributed 50 billion steps data. So those were like we had that as an exposure, and our EHR data is again very longitudinal. So we use a free map, which is very established in bioinformatics world. What they do is they have these ICD codes, and they basically collapse them to reduce the collinearity, and they produce the fee codes. So, for instance, all osteoarthritis ICD codes would be collapsed to like one fee code for osteoarthritis. Cardiovascular disease would be collapsed to one fee code for CVD. Diabetes would be collapsed to diabetes, type 2 diabetes, or type 1 diabetes, kind of those things, sleep apnea. So you'd be able to collapse these 16,000, more than 16,000 ICD codes to just 1,700 fee codes, which is much more manageable. Uh, and again, like since it's a cloud platform, scaling the computational resources as needed is super important. And again, like, how you want to scale up, like how many CPUs or how many RAM you want, scaling up the cloud platform was very important and needed to conduct this analysis. And then, as I said, like, cleaning data. So one way to clean the data was we use our compliance definition. So one of the compliance definition was 10 hours wear time, which is what we took it from literature. So if you see the other work which is done in Enhance and other actigraph or physical activity literature, is they basically use a criteria is a participant should have at least 10 hours of wear time for the particular day of data to be considered as valid. So we basically excluded the days where participants wore the monitor for less than 10 hours, or we excluded the days where they took less than 100 steps per day because that did not seem clinically plausible. And we wanted to compare apples to apples, not someone who would be having 50 steps versus someone who was having 5,000 steps. That wouldn't make sense. So just to compare apples to apples, we excluded days which were less than 100 steps or if they were more than 45,000 steps. Like that seems like an extreme outlier. And we excluded participants when they were less than 18 years of age at the first Fitbit day of monitoring. So again, like, then once we have all of those things, summarizing and visualizing the data is super important to basically get the story and to get the answer to the research question. So we basically summarize the information using FIVAS and use the user design processing. So if you see on the figure on the x-axis, there is an odds ratio and the y-axis is the p-value. And these are all the fee codes that I mentioned. And it's just putting up like, okay, tell me which diseases are most associated with step counts, which each additional 1,000 steps per day, which diseases are coming up to be most, like which diseases are highly associated with steps per day. What we saw is if you see the upper left quadrant, these were all like, if you take more steps, then you have uh, lower odds of getting these diseases. So that is sleep apnea, obesity, type 2 diabetes, heart failure, GERD, depression. We also had something like hypopotasemia, dysphagia, which did not make clinically uh, did not make sense. So what we then did is we then picked up based on the number of events and based on the clinical judgment, we then identified these conditions, that is diabetes, sleep apnea, obesity, depression, GERD, and essential hypertension as being the conditions which were associated with steps per day. Are there other conditions? Yes, but that we did not take into it because clinically did not we didn't have mechanistic rationale to basically uh, understand this association. And second is the number of events for those conditions may be too low. So there was a reason we use what I want to say is like using data, clinical judgments, and evaluating it together, making understanding of what this data is able to tell us. So we use those three pillars to basically better understand. Then, as a final step, as I said, this is team science. I didn't do it all by myself. We had wonderful team, like a amazing programmer. We had a clinician, we had a biostatistician, myself, a physical therapist, physical activity researcher, like amazing team science who were able to do things together and populate this research. So again, like there are a lot of resources which are available for all of us if anyone is interested. But what I want to share over here is this is more about like team science or like more about working how to use the data, how to use wearables, and how to get insights to answer clinical questions that you may have when you see patients in clinic, or just like questions that you have while doing research and how we can better solve things together. So again, just want to thank everyone and also all of us teams. And again, if you have any questions, let me know. I want to make sure that I keep time for questions since the questions are going to be at the end. So yeah.
Thank you, Dr. Master, very much. People, if you have any questions, I have some, but I'll save some time later.
Are there any questions? Please type them in the chat box. Dr. Mehta, I think you should start. Maybe they're just shy.
Yeah, I will. I'm sorry, I'm not a good typer. I'm known to make many typo mistakes. So I'll just speak if that's okay.
Yes,
Uh,
yes.
Yeah.
Go ahead.
so, Dr. Master, I have heard about your work and all of us, and that's very exciting. I recently became aware, this hasn't been my past interest, but something that I'm looking forward towards, which is, being able to access and analyze big data sets for certain questions. And I just came to know that we are actually a member of all of us as well. And the person listed there is, uh, I think, the chair of the Office of Sponsored Programs, which is just another way to say that we have the person who looks after all the grants that come in and making sure that we are in compliance and everything. So I guess if we are interested in accessing this data for some of the questions we may have, or what kind of even data that we're looking at, uh, where do we start? That was question one. And question two is, what does it have the socio-demographic data, living situation, and some of the, you know, companionship, like where do they live and all those kinds of things, like living situation in terms of family and everything.
Yeah, and that's a great question. I would definitely encourage you all to explore this public website because it's available over there. So if you go to researchallofus.org, I'll just share my screen. And since you already have a Jura, you can register. But before that, I think you're looking for like click on data browser and you can look at all the different types of data types that's available. So let's just say if you're looking for age, you can type age and then you will figure out like, yes, there is like age available in EHR, there's age available in social factors of health. A lot of those things are already available before you even have to go to the researcher workbench and access the individual level of data. I would definitely encourage you to open and view our data browser, which is a public website.
Okay.
Let's just say if you're interested in stroke. If you are interested in stroke, and if you just see the conditions, like you'll be able to see like how many people have cerebrovascular accident, you'll see they're 1460. So at least it will give you a starting point to get started with, okay, what is the incidence of particular condition you're looking for? And again, this is just like a high level. Think of it like as you add and if you refine your criteria, like if you collapse all the ICD codes, you might come up with different numbers, but at least this will be a high level way to just familiarize yourself with what is available over there. In addition, there are different surveys which are available. So I'll definitely go over here and look at the surveys. So basically, there are different types of surveys, and I'll just click on the basic survey, and you can see all the questions that have been asked, like which country you were born, what's your marital status, are you covered by health insurance, kind of like those kind of questions, like what is the annual household income, do you own or rent a place you live, a lot of those questions which have been asked and it's available on researcher or on participants. So for instance, what is your marital status? Like you would now know like 44% of the participants are married and all of those things. The other stuff that I really want to bring up is also if you click on our support hub, and if you go with working with the data, and then there is going to be like a data characterization and quality artifact. So if you click on CDRV8 data characterization report, we have like a lot of reports like, okay, what is the growth in the data? How much data has increased? What are the new data types? A lot of those information are already available over there. So you can take a full look at what the data is and how things are available. So again, I'm just sharing you a couple of resources that are available to get yourself familiarized with the data. And then once as you're working on creating your account, because when you create your account, you have to sign in, have your two-factor authorization or login.gov, have all those processes in place, and then, yeah, get started.
Thank you. And I think we had a question in chat.
Yeah, I'm like, there are a lot of recommendations if you look at like resources and trainings. Again, I would not call myself like, like I'll definitely look at all of those things, like, working with data. So getting started with the data, there are a lot of resources over there. There's stuff like UK Biobank, there's stuff like Enhance. There are a lot of big data sets which are already available. So again, it's just like a learning curve as you're looking into the data sets and making sure you're partnering with right people. And you don't have to be knowing everything outright. But if you have a right question partnering someone with your institution or someone outside your institution, because again, it's a cloud platform, you can do a lot of collaboration and team science. But I did share like a support link where you can basically see all the trainings, understanding the data, like how the data is organized, working with data. So I think they have like an graphic also, like, like creating the workspace, like how to create the data. Like they have a lot of those tools and it's very well organized. So if you click over here, definitely like, and because again, the data is definitely different. As a rehab researcher, again, I was not well versed with that. I was not well versed with OMA and all of those things. So like they use common data models. So like understanding all of those nuances of like how data is organized, what it is, what kind of data are available. So I think going to this support hub and getting started guide would be the first thing to get yourself organized, like starting your first research project. Like they have step-by-step procedure, like how you can create a workspace. Like they have like a lot of those step-by-step articles which you can look over and see.
Okay. All right. Thank you so much. Are there any other questions from our audience? We still have a few more minutes. Don't be shy. Okay, I have a question, Dr. Hiral. So, these are wearables, right? So we're looking at wearables. I was just wondering, how do you address the quality of the data? For example, when it comes to walking, do you consider the quality of the walk, or is that like an exclusion in your study?
No, I think that's a great question. So again, like with the wearables with the Fitbit data that we have, like I just showed the volume, like how much steps per day, because that was easy message. But I think we look at intensity. So they have intraday steps per minute data, and they also have intensity based metrics like light activity, fairly active minutes, a lot of those sedentary minutes, a lot of those data already available, which I did not show it over here, but wearables do capture those kind of data as well. And that would be an additional research question, additional research line that can be answered. So as I said, like it is possible, sky is the limit. I know there's a research who have done like step counts, like steps per minute to act to intensity based threshold. They have translated that recommendations also. So people can actually play around and look at the intensity based metrics and see how it aligns.
So just to follow up with that, because in the Philippines, we're also following the 10,000 steps, but really in time, one of my senior accreditors yesterday, she said that she just took steps, but in place. Like she was just stepping in place. So what can you say about this manner of getting the data, right? So they still get the 10,000 steps, but they're not actually moving. They're just stepping in static. What can you say about this? I think this is like a limitation of the sensors, right? So what can you say?
No, I agree. That's a limitation, and that's where I think we have with as the wearables have evolved, like a lot of things can be studied. So, for instance, they also have heart rate data, so you can see what the heart rate values are. You can look at the heart rate variability. You can make a corroboration and try to better understand. But no, I agree. Like you won't actually know like how people like are they going uh like how they're getting those steps, whether it's spot marching or whether it's just walking. That would be a limitation for sure. But I think there's a way to better capture that. I think those are very extreme edge cases. Most people would get steps by moving around. I think these are some extreme edge cases. Maybe we can also complement it by diaries and logs. Like if at all you're doing like a research study, you can basically put in a log or diaries to basically put in some of those information to see if there is an additional cleaning needed. Since this was like since we wanted to have a low lift, we were just thinking like, okay, off, and especially when you have such a longitudinal data, like 4 years, 5 years of data, it really provides insights on someone's behavior, and hopefully it will provide like it would eliminate this kind of like these edge cases, as opposed to if you have just 1 or 2 days of data versus if you have someone's 4 to 5 years of data, then it becomes more consistent and you are basically able to get more into the behavior and the insights of how they're getting these activity accumulated over time.
All right, thank you so much for that. I think we have room for one more question. Is there anyone in the audience who would like to have the last slot for a question? Anyone?
I don't have immediate question, but Dr. Master will be reaching out to you because there are a couple of colleagues that I have here on this on the attendees here, and we are interested in some of the work that we want to do in geriatric rehab, and we just need some foundational pieces of information that we can use to build our case and just running some small data analysis. So I was hoping for we have an engineering faculty who's all into data analytics, so we wanted them to be here as well. Unfortunately, I don't see that she's here, but I'll send the recording to her so that she can get a sense of the data analytics side, more just, you know, big model and all that, and we can bring our clinical questions. So
Yeah, I think that is the best team science. Like let them do all the cloud solutions and cloud architect,
yeah,
and then you get in all the clinical questions. I think that's the best route to go with.
that's the plan. Yeah.
Yeah.
All right, if there are no more questions, we'll give you back 3 minutes of your life. So thank you so much, Dr. Hiral. This webinar is recorded and we will be sending out via the link in the web page. So just stay tuned to that so you can watch it again. Yeah, and thank you so much for attending. And I hope we learned something. And please contact Dr. Hiral if you want some collaborations, or you can actually contact Dr. Mehta if you're associated with Dr. Mehta or you know his email. We can create a collaboration with any of you guys. So thank you so much and have a great day.
Thank you so much for inviting me. Bye bye.